and welcome to our fourth edition of Palooza Tuesday, powered by Process Palooza. My name is Tracy O'Rourke, and I'm going to be your host for today's session. I'm the Chief Innovation Officer at GoLean6Sigma.com and a Lean Six Sigma instructor at UC San Diego Extension. So for those of you that have joined us these last few weeks, we have had over 500 participants in each session and growing. Wow. But if you're new to Process Palooza or Palooza Tuesday series, let me tell you a little bit about how this was created. In normal times, I guess that would be pre-COVID, UCSD hosted Process Palooza on campus, and it was a day-long event packed with keynotes, workshops, process improvement competitions that were really fun, and celebrated continuous improvement. And Process Palooza was scheduled back in March of this year, but like everyone else, we had to adjust with the coronavirus outbreak and quickly shifted gears to bring content and panels online, and thus Palooza Tuesday was born. And we wouldn't be here without the support of our sponsor, Koali Build. They bring business processes to life with digital forms, automated approvals, key integrations, and putting your Lean Six Sigma vision into action by helping you build powerful, interactive, secure, and mobile-friendly process flows with no programming needed. I like that. I'm not a great programmer. So before we get started, we actually have a quick poll for you. We want to get a feel for our attendees for this session. So what we want to know today is, what is your level of familiarity with Lean Six Sigma and or continuous improvement? So go ahead and fill out the poll. There's a varied responses that you can answer. I would say that my guess initially when we started Palooza Tuesday was that most people knew about process improvement, and surprisingly, I was wrong. There was a lot of people that didn't know about process improvement at all. So go ahead and vote, and we'll see what our attendees are like in this session. All right, we're going to share the poll. Okay, so 42% say they've had some introductory training and have helped with a project. That's great. Followed by 19% of people have heard of the term but don't know anything about it. So that's second place. Followed by, I have had formal training and have completed at least one project. That's 18%. And then I am able to coach others. I'm guessing that's the most advanced level, 14%. Followed by, I've completed 2 or more projects. So thank you very much for that information. That is very helpful. So just so that you know, for those of you that really would like to learn a little bit more about Lean Six Sigma, the UC San Diego's Operational Strategic Initiative is hosting a white belt session focusing on the basics of Lean Six Sigma this Friday, June 5th from 11 to 12 for free. So if you want to join, go ahead and put that on your calendar if you want to learn a little bit more. Okay, a few housekeeping rules. Well, not really rules, just items and logistics before we get started. All sessions will be recorded with closed captioning and posted on the website at processpalooza.ucsd.edu. Question and answers will be open the entire session. So go ahead and fire those questions in our chat window. Whenever you have a question, we'll be mostly reserving them for the end, but we may be able to answer some questions throughout. So go ahead and put those in there. We will they'll also be available on the recorded video later on. And lastly, the end of the session, we have another prize to give away. It's a $500 voucher for a project management or Lean Six Sigma class at UC San Diego Extension. And don't think you can't apply if you're virtual, because there are a lot of online classes to attend remotely from anywhere in the country or really anywhere in the world. So definitely, if you've got fast fingers, you definitely want to participate in answering the question at the end. So why don't we go ahead and get started? I know you guys are really excited to get started and hear our presenters today. So our presentation today, we're going to be diving into healthcare at UCSD Health. Specifically, we'll be hearing about lean thinking during the COVID pandemic and how UC San Diego Health is navigating the unknown. So I'd like to welcome our transformational healthcare team from UC San Diego Health. I love these people. I was there last week with many of them. So our panelists are Carrie Benjamin, a senior coach. Where are you, Carrie?
Thank you for having us.
Oh, there you are. Hi. Lily Angelosi, lead coach. Where are you, Lily?
Hello, I'm here.
There you are. All right. Mike Spencer, lead coach.
Hey, everyone.
And finally, Ashley Gambier, senior director.
Hi, looking forward to today.
Me too. So everyone on the panel, like I said, is from the transformational healthcare team at UC San Diego. Welcome, everyone. Thank you so much for attending and sharing your knowledge. We are very excited to hear your story. So with no further ado, because I'm tired of talking and people are probably tired of hearing me talk, we're going to go ahead and give it to Carrie to get started.
Great. Thank you so much, Tracy.
You're welcome.
Next slide, please. So we just thought we'd do a quick vocabulary alignment here. Lean means creating more value for customers using fewer resources. And a few of the things that we're going to talk about today are daily engagement system, plan, do, study, act, and rapid process improvement workshop. These are a few things that we use as tools in our tool belt at our UC San Diego Health and with our lean team. Next slide. So the COVID-19 pandemic, it's really greatly impacted everyone, how we live, how we play, most especially how we work, particularly in healthcare. It's a novel virus, which means it's new and never before has our US healthcare system dealt with anything like it. There are still a lot of unknowns, including treatments and processes, how to properly contain or deal with the virus, and what workflows should be used. This compelled the development of standards to be used as a basis of operations, which needed to be communicated quickly throughout the organization. Next slide, please. The departments in our organization that run clinics and most things outside of the hospital are under the umbrella called ambulatory. This part of the organization set up a command center, which you might typically think of within military functions and sometimes referred to as a war room. This function used to provide centralized command, respond to issues that arise, coordinate activities and teams and projects related to the pandemic. The leaders in this command center immediately recognized the need for testing capabilities outdoors to accommodate COVID symptomatic testing without the risk of having these patients in clinics possibly spreading the virus. The tents were ordered quickly and the process of setting up drive-through testing began. Operations became a response to the crisis, which naturally puts everybody into firefighting mode. This mindset is very different than what you might think of when you're working with a process improvement mindset. As with any location that is set up, the fire inspector came along to ensure safety for team members and patients. They provided feedback about testing areas such as where the heater should go, where the generator should be safely located. Things were moved, flow was improved. We did things like move the tent from the path of car exhaust to prevent the exhaust from being inside the tent and causing additional health issues for our team members or our patients. These teams quickly realized that they did not have computers to verify orders or printers to put label on testing specimens, and they were running back and forth to the clinics. So we used process improvement thinking to determine what we needed and where we needed it. All these changes were documented as the next location was set up, in essence using continuous improvement methodology as standard work was developed from the lessons that we learned. I might challenge you to think about things that you have done along your career and what approach you took to make improvements, even and maybe especially through difficult times. One of our senior directors, Alan Tran, describes how lean methods have impacted their teams in this time of pandemic. Typically, IT changes need to get vetted by a change control committee. This committee meets 3 times a week, maybe 2 or 3 times a week. And what they do is they get all the changes that need to go through and they batch them and they bring them to this committee, and at the committee, they just set priorities, figure out which resources need to go be assigned to this. So basically what we call this is batching in lean thinking. If you're not in healthcare, you may not realize how all levels of the organization are reliant on electronic health records for their workflows, from patient scheduling, registration, preparing patients for visits or procedures, to nurses and doctors. Everyone uses the EHR. Epic is the software used by San Diego Health to virtually click the patient through the proper screens in order for the next person to be able to do their work. IT staff are sometimes unsung heroes in healthcare, so we felt it really important to share the impact of their work. So they started urgent priority change control process for matters related to workflows for COVID to enable quicker escalations. By enabling the one item flow, they modified an old version of change control and began to process where approvals can happen during a daily meeting or via email, depending on the priority, and that really enabled flow. So that's different than batching because we have flow now to get escalations and things running through the system in order to respond properly for COVID. Additionally, their team made modifications on how they communicated with each other. You'll hear a little more later in this presentation about our daily engagement system, but I will just preface this by saying that our teams meet daily in a huddle style format to address specific topics. Previously, the IT teams did these huddles maybe 2 or 3 times per week. Different teams ran different days, so you never knew who you could really get in touch with for escalations. And so the daily engagement really began for these teams as spurred by COVID. So they had task meetings specific to Epic, action items were assigned to everybody, and it became visible for all responsible parties, and deadlines were assigned. Our health system CEO, Patty Mason, began a daily engagement huddle for COVID-19. All the IS teams recognize the opportunity to do huddles at all levels of the organization to enable priority setting and escalations to get the top of the organization as quickly as possible if it was needed to go that far within 24 hours. Alan describes how much this has helped his team in addressing issues, as well as getting info from the top cascading down to all frontline levels and aligned with priorities daily. Next slide, please. So the preoperative area of a hospital is responsible for preparing patients for surgeries and or procedures. Even though we have been going through a pandemic in the country and actually the world, and many elective surgeries have been canceled or rescheduled or set aside or maybe not deemed as essential, there really still have been quite a few that are essential. This department is required to continue on with their work. Our nursing educator in the pre-op area, Criselda, she realized the importance for the area to develop workflows around patient testing for COVID before being admitted to the hospital. They began working on documenting everything, including scripting for outbound calls, helping patients schedule, and verifying test results before clearing the patient for admit. Standards were developed and rolled out through the daily engagement system to inform everybody of the new policy and to ensure the method for escalation of any issues that came up related to the testing prior to the patient arriving for check-in. They solicited input from our team members about these standards and made edits for improvements. The person on the front line really is the one that knows which edits need to happen. So our leaders really took on an improvement mindset, and they've continued to refine as needed to meet the needs of the team members and the patients. So pulling all of this together, you might wonder, how are all these initiatives supported? And how have we made these changes and improvements seamless to our patients? Our ambulatory command center determined a need to set up an employee exposure line specifically to COVID. This was initially dedicated to scheduling for drive-up testing for symptomatic patients or team members. Our director of ambulatory nursing, Chris Henderson, took on responsibility for managing these call center team members and ensuring everything was staffed up and resourced as needed when available. The command center found needs beyond the initial plan, so they began using improvement cycles to utilize available team members for these additional needs. For instance, if an employee was exposed to COVID and they had a concern whether they were positive or not, we needed to be able to schedule that right away. No batching. We need a flow immediately. We need these staff to get tested and check out, because if they are available, we need them back on the front lines as soon as possible. And if not, we need to be able to take care of them and isolate them right away. So our escalations through our daily engagement system with the command center revealed that we needed to figure out a way to handle a multitude of testing for additional populations. For instance, we were testing first responders, staff that were concerned that they had COVID-19. Our leadership opened it up for any staff that had symptoms could use our testing facilities to be tested, whether they're a UCSD patient or not. As I mentioned earlier, we needed to figure out how to do testing for pre-op patients, so they were added to this mix. Additionally, our leadership started doing testing for all employees, even if they're asymptomatic and didn't have any symptoms of the COVID-19. So they did this through priority units. So for instance, the ED personnel are really on the front lines. They may have been exposed quicker. So they started with the ED, went to the ICU, then to the medical units. And this employee exposure line is handling all the calls to make this happen, to get the orders placed, and to get the people scheduled in the drive-up testing where needed. Additionally, we opened up to our community. Our skilled nursing facilities really needed a way to test their patients and their staff. So we started opening up to them, and we're also using this line to help with that scheduling. So next you will hear from my colleague Lily, and she will share some PDSA cycles that we use to continuously improve methods and processes.
Great, thank you so much, Carrie. I just had a quick question for you. 94% of problems are due to process, not people. And I have found that people still want to believe it's the people. And so I just wanted to know, has Lean Six Sigma helped the mindset at UCSD Health? Or maybe they were already there. Did they always say it was the process? Or do you feel like people now are saying, no, there is a shift. It isn't the people, it is really the process, and we got to improve the process. What are your thoughts?
Well, I think that's going to be ongoing continually. Everybody's always learning, and sometimes you just jump to it being people, but I think it's a continual learning of everyone. And if we have standard work and we can rely back on that, and we use our frontline employees' perspective to develop those standards, then they're part of it and they feel part of the solution.
Yes, very helpful. Thank you so much, Carrie. Okay, Lily, let's hear from you.
Good morning, everyone.
Good morning.
Hi, so good to be here. Thanks, Carrie. As Carrie's mentioned, the PDSA thinking has been always supporting our operations, and especially during the unknown, the trying time. And today, I'm going to focus a little bit more on the learning part of the PDSA cycle. We all already know that the PDSA has, given us a structured approach as to solve problems and maintain the gains. But today, I'm going to focus on the learning journey that we have been using this thinking to help us through the pandemic. So at THT, Transformational Healthcare, we find it's always the right time to coach and learn, and never let a good crisis go to waste. I heard that a lot lately, so I'm going to use that. So through this pandemic management, we wanted to utilize this opportunity to develop our organization's own problem solvers. as Tracy has mentioned, most of the problem happened because of the process are broken. It's already not in place or standard work's not followed. So at this time, we find it's really important for us to engage our teams and also utilize everyone's talent to learn this new curveball that this global pandemic threw at us. So the global pandemic, as you all know, that in the last 8-10 weeks, quickly we have to change everything we do, including the way we work, including the way we live, such as grocery shopping, pick up a mail. As simple as I want to hug my team member because we gained some, wins. It's all get changed. We all have to change all of these little details. So of course, our healthcare system has been hit by this too. We have to quickly learn, relearn, and unlearn a lot of existing process to accommodate the need to deliver care to our patients and also protect our staff. So as far as you remember that back in February, when we first UCSD Health was one of the 3 hospitals nationwide that taken in the evacuees from Wuhan, China. At the time, we didn't know anything about the virus, and we didn't know anything about these patients because they were not our patients. We didn't have their medical records with us. We have to learn on the go. And we have no idea. The only testing opportunity was in Atlanta, CDC's testing center. And how do we administer drugs? All of our team get together, but we know that for sure that with all of us learning this together, we can get ready for our patients. So immediately we set up the hospital command center, and then we gathered all the cross-functional teams in the same room. Let's study, let's learn how can we get ready for these patients. And then, so we quickly developed process map. As interesting as it is, the regular admission process is not safe enough to transport patients from Miramar base and Navy base to our hospital. And how do we testing? How do we keep the communication line with CDC on a daily or hourly basis? Because that determines a lot of the treatment or discharge planning. And how our pharmacists, Ellen, Tran, and others, and we quickly developed with our nurse and doctor infectious disease doctors together, we figure out how do we deliver the test result, the specimens, and how do we collect the how do we best administer the medication, etc. So it's all on the go, constantly learning 24/7. We set up the process for us to beat this virus. And then I would like to see, I was in the middle of this learning curve and getting excited, and we're really taking care of doing our part to serve the world, the 300 some evacuees from China that who were temporarily placed at the Miramar Navy base. And I was serving the part of the logistics chief at the Incident Command Center, and suddenly we have some message and discussion around, hey, we find that we have a need to, our patients don't speak English. 6 out of 7, they don't speak English. Does anybody speak Chinese, speak Mandarin? So I was there, happened to be there and working on the process map with my pharmacist. And then I heard that I just raised my hand and, hey, I can speak Mandarin, it's my mother tongue. And as little as I knew, the 10 days of learning journey with my Chinese patients started there. So quickly we went to Gamba, we went go and see and find out why the patients are, there's certain treatment plans or communications not going through as clearly. We felt there's some sort of barrier. So we went to the patient room and quickly we find out one of the patients that her food tray is always full, and her room stacked with all the cold room temperature bottled water. So I asked her, so Miss So-and-so, why are you eating? You know, it's extremely important to keep the nutrients in your body when we're fighting this virus, and also keep the fluid, keep yourself hydrated. And she, you know, quietly but says, you know, I don't drink cold water. I don't drink room temperature water, and I cannot eat American food because I don't eat cheese. I don't, you know. I said, Miss So-and-so, why didn't you talk to our doctors about this? She says, you guys are doing such a fantastic work taking care of me and my family. I don't want to add more burden to you. So quickly, we know that now we learn from our patients what the need is, and our dietary team, let me tell you, they are fast. They quickly deliver the hot water, they quickly figure out the plan, tell the kitchen, cafeteria, cook vegetables, no cheese added, this kind of meal, and deliver to the patient. And then problem solved, she's suddenly so happy, and she couldn't say enough thank you to us, and they're just small things. And then another learning aha moment for us was the daughter and mother they were in the patient room right next to each other. And the most important thing we find out quickly was the first thing they asked the doctor, not about myself, how am I going to treat, how are you going to treat me, is how's my mother doing? And the mother would be, how's my daughter doing? They're in isolated rooms. They're away from their family. They're isolated. They're not feeling well. So, but the first thing they ask the doctor is always, how's my daughter? How's my mom? So we prepared. The next day, our doctor walks in without violating any HIPAA. We brief the daughter and the mother that they're doing fine. They're doing great. This is a treatment plan. You know, you just see the relaxation. And on a Saturday morning, I got a call from our command center. It says, Lily, you need to come in. One of our patients are not feeling well. They're, you know, having some communications. You need to come in. So I ran in, and he's totally fine. But his worries was not about himself. He said, I'm doing great. I'm healthy and young. I know I'll be fine. But my two young little kids and my wife are still at the Navy base. I don't know how they're doing. She cannot take two little ones by herself. She doesn't speak English. So we quickly arranged the plan to communicate with our base and then connect the family. And this gentleman just couldn't say enough thank you to the doctors and all of the staff who took care of them. So these are the learning journey that as healthcare delivery, I have to always come back to our patients. You know, they have the similar diagnosis and they have the similar journey to come to us. However, we have to remember they are, first of all, unique human being, and their need is very unique. Sometimes you just don't know. All we need is to take the lean thinking, go and see, to talk to them. So that's our patient, learning from the patient. How about we learning, because it's still new, we're learning from the world. And we know from learning from China, from Italy, from New York City, our own city, that there could be potentially run out of shortage of hospital bed. So our Instant Command Center immediately set up a really well-structured team, about over 100 team members involved, cross-functional, about 17 disciplines, all the way from RT, PT, pharmacy, infectious disease team, transporters, imaging, pharmacy, you name it, we have representative at the table. We immediately deployed the plan of a 10-phased approach in case of the surge. We developed the students' dorm into 150 additional rooms. In addition, there's a surge, so we can accommodate the not so severe patients. And we developed the plan to house our doctors and nurses who just need a quick nap, or who don't feel very comfortable going home in case they feel like they don't want to, give the virus to their family. So we quickly developed the plan to get ready our inpatient space ready for the surge. And another one, the last one I want to share is also we're learning from the world, is because I'm on the WeChat circle group of 100-some doctors. They're Americans and Chinese doctors. I'm assuring you, as of today, they're still exchanging the best treatment plans, medications, and nutrients, and the latest news from all over the world to figure out how to deliver care to our patients. So all of this is our PDSA learning journey that we're still going on. And I assure you that as UCSD Health, with this strong structure and learning from each other, relearn and unlearn something we didn't know, we did know that doesn't work anymore, quickly change to adjust, study and adjust. This helping us through this journey so far.
Thank you. Thank you so much, Lily. That is very interesting. I actually have a question from Annie, and she wants to know, what part of the PDSA cycle would you say takes the longest and requires the most resource?
That's a really good question, Annie. Thank you for asking. So for plan on the top, you will say we usually spend about 50, sometimes up to 80% of the time to work on that part. That's on the left side of our A3 forms. Because once we have the root cause, really study our current state and set the direction, set the target, and then we find out the root cause, not just the symptoms. We can quickly find out move on to the right side of the form to to come up with the best countermeasures to experiment.
All right, Mike, why don't we go ahead and go to you?
Thank you very much. Thanks, Lily. So we've heard from Carrie specific examples of processes that we either had to start from scratch or radically change, like testing tents and exposure lines. And we heard more generally from Lily, the PDSA cycle. I'm going to pull back a little bit and talk about the management system as a whole. And I saw in the Q&A that we had a question already from someone who said, do we have a standard operating procedure to respond to emergencies? And the answer is, not only do we have an SOP, we are required within healthcare to have very detailed response processes. Because as you can imagine, in healthcare, we have to be in the position to say, whatever the crisis, whether it's a COVID-19, which comes along once in a generation or more, but in California, if it's an earthquake, or if it's a situation where our computer servers are down and we don't have access to our electronic medical records, or we've had a situation where we had a flood in the basement of a hospital and we lost access to our operating rooms. Whatever the crisis, we can't afford to just say, well, I'm sorry, we can't take any patients today. We have to be able to take care of patients who are coming in from a motor accident, or who need infusions for their diabetes, or who are cancer patients, whatever, having a baby today. We cannot afford to have any interruptions to healthcare, whatever the crisis. So we actually have very detailed procedures that we can invoke at a moment's notice. And we did that with COVID-19 in February, March. So the question is, do we have a system that will both work for emergencies and for everyday care? And I can tell you that the kind of culture that we're trying to, and I think succeeding, in putting in place in the University of California, San Diego healthcare, that culture is very different from what you might imagine in something called a command center. And a command center, as the photo on the left there implies, with someone who is an incident commander and literally wears a jacket with commander on the back, and someone else has a jacket with infrastructure chief. That's very different from our everyday culture, where we encourage a culture of empowerment and very distributed decision-making. In organizations with 10, 20,000 employees and nurses and healthcare workers, we want to solve problems as near to where they arise as possible. We want to empower people to look after our patients, to make the right decisions for those patients, to solve problems, to make decisions that are in the best interests of our patients as rapidly as possible. So in an emergency, we are looking at people and saying, okay, you're in charge, make a decision rapidly, communicate it rapidly. How can one system meet both those needs? And that's what we're going to talk about next. So next slide, please. So we'll take a minute just to look at the concepts very briefly. What we call our system is a daily engagement system, and we chose that name very deliberately because it's very important for us to promote engagement of everybody, and it is a system. And the other key word is it has a daily cadence. If you read the literature or you work in other places, you might see this called a daily management system, or DMS. And we came up with a catchy acronym AIR, it's the air we breathe. And the three components of this system are alignment, improvement, and readiness, and they're all important. Alignment is to indicate, are we all rowing in the same direction? Are we all aligned with the same mission, vision for the organization? And more specifically, are we aligned with the same goals? Are we aligned with the same quality and safety and respect for people and effectiveness goals? Improvement is to do with the culture and the actions of, are we improving our processes all the time, everywhere? I talked about the culture of empowerment. Have we empowered and enabled our people everywhere to not just do their job, but improve their job all the time, everywhere? And readiness is, are we ready to serve our patients today without harm and without delay? And when COVID hit, alignment became clear. It wasn't 100% about COVID-19 because, as I said, people still have babies, people still have car accidents. But it was, let's say, 80% about response to COVID. People would be presenting at our clinics, at our emergency department, with concerns about symptoms. We needed to be ready in new ways, personal protective equipment, symptoms testing. So alignment was pretty obviously about COVID. And we needed to gear our system around readiness, our employees, our nurses, etc. So how do we do this? Click, please. And this is a little bit of an involved graphic, but let's take you through it. Across the top, you'll see 5 tiers. Tier 5, 4, 3, 2, 1. They represent basically an organization chart. And tier 5, we're calling the tier or the level for the chief executive officer, the CEO. And on the right, you'll see tier 1, which is the front lines of healthcare, the departments, the clinics, the ICU, the intensive care unit, the emergency department. That's the front lines of healthcare. And so they represent the tiers, the levels of the organization. Down the chart, you'll see the alignment, improvement, readiness elements. And that just graphically shows that every one of those tiers should be talking about and discussing alignment, improvement, and readiness every day, just in different mixtures. The CEO will be talking a lot more about alignment and less about readiness. The front lines of healthcare will be talking a lot more about readiness, less about alignment. But the key is that bottom row, 7:30 a.m. on the right, 10:30 a.m. on the left. And that's where the daily bit comes in. Every day, before COVID and during COVID, we were having conversations, we still are we ready today for our patients? When COVID hit, those conversations just changed in nature. Instead of talking about regular staffing and regular technology and equipment, we just changed the conversations about, how's our PPE today? Do we have enough masks? What's that new policy about masking? Did we change the policy? Did we communicate it? And if I'm the clinic manager for dermatology, and I have an issue with 7:30 today, I can communicate it to my director by 8 o'clock. My director can communicate it to his or her VP, and by 10:30 today, if we collectively have enough issues about, let's say, the PPE policy, the CEO literally can hear about it by late this morning. And if that needs a systemic response, that response can come by this afternoon and be dealt with. So the answer to the question I posed myself, do we need to change our system during an emergency? Do we need to put our normal system aside and replace it with something? No, we just need to adapt the system to an emergency. And as we're recovering from COVID, we will just to tweak the system back to normal. So alignment, improvement, readiness, the daily engagement system works for both. And now Ashley is going to talk about our the importance of the role of leadership.
Thank you so much, Mike, for giving us some insight on the daily engagement system. Very, very helpful, very well explained. We do have a question from Tamara. She's looking for some advice. She wants to know, did you receive pushback regarding ICS? For example, I was trying to get a group to use improvement process in the middle of an open EOC, and the incident commander insisted that improvement work is not compatible. What would you say to that? I'm
not sure what an open EOC is.
I believe that might be the command center. I'll see if Tamara will respond to that and we can ask you more specifically. I have one other question for you, Mike, and that is, did you find that people were very open to embracing the daily engagement? Did you see a lot of resistance initially? And how did you, can you give us just a quick thoughts on how you overcame it?
There was a little bit of resistance we found between the people who had already set up I'll call them fixed, well-defined systems to do with emergency management, because it did look sort of on paper like the daily engagement system was, if you like, replacing well-established emergency management procedures. But it didn't take long before we both realized that the two complemented each other. We weren't pushing one aside to be replaced by the other. And we all wanted the same thing. We wanted clarity of decision makers, who's making the decision, clarity of communications, rapidly making the right decisions. And so it wasn't long before we said, okay, actually these daily tiered cascading huddles, rapid documenting of the decisions, communications. And so before long, we had these huddles scheduled on a daily basis from 7 a.m. through to 11 a.m. And they were a well-oiled machine very quickly, and both emergency management and routine operational management were involved. And before you knew it, you would dial into let's say a tier 4 in that diagram on the screen there, a tier 4 huddle, and you'd see 40, 45 people dialed in. And you knew that those 45 people were coming out of that huddle supremely informed about what was going on that day. And they would then inform their folks. And the speed of communication was superb.
Excellent, Mike. Thank you so much for that response. I think there will be a few more questions that we can answer at the end as well. We're going to go ahead and send it over to Ashley.
Hi, everybody. Thank you, Tracy. Thanks again for tuning into Palooza Tuesday this week. I'd like to spend the next few minutes focusing on the critical role of leadership during this time. What you've heard from my colleagues could not have been achieved without leadership support prior to and during the pandemic. Over the last 2 years, there's been a focused effort to develop a culture of problem solving. It's always been a part of culture, but the focused effort is really on developing that existing culture and expanding it to be as inclusive as possible, implementing the management systems that Mike discussed with you to provide the structure to support success, and that's really made a big impact. This work over the last 2 years was tremendously helpful when COVID hit San Diego. We were able to tap into the escalation pathways that have been defined. We also have clearer pathways in the other direction to cascade information quickly all the way through the organization. The biggest part was the empowerment that we're developing in every single member of our community to identify opportunities for improvement and bring them forward using the PDSA Plan, Do, Study, Act model that Lily shared with you and A3 thinking. You can see in the picture on the left here, the social distancing measures that a local clinic implemented to protect their patients and team members. Clean and dirty pen cups, special signage, and an extra table to ensure 6 feet of separation. These were all ideas that came from people working directly with our patients. Balancing the urgent versus the important. This is always a challenge for leaders, but even more so during an emergency. And I'd say one of the biggest challenges for leaders after the first week or two was managing the operations on a daily basis while also responding to all the COVID-related escalations. It became an art of balancing the urgent versus the important, and teams shared the load. They used visual management to ensure that they weren't letting the emergency compromise our care, our quality, or our efficiency. But leaders play a critical role in giving their team members guidance on what to prioritize and to adjust those priorities as needed to focus on the crisis at hand without compromising the rest of our mission. During a crisis, it can be really easy to make the mistake of forgoing long-term strategies in order to do the necessary firefighting. And at some point, that becomes unsustainable and can hurt the organization. When I was a little girl, I was on a flight that had some turbulence, and it was announced that everyone should be sure to have their seatbelt on securely. I was concerned, but a wise person sitting next to me said, just look at the flight attendants. They're not worried, and they fly all the time, so just follow their lead. It's the same with any leaders. People are watching what you do much more than what you say. If you are asking people to wear masks, you better wear one yourself. If you're asking people to trust, you better not break it. And when we tell our team members that they're empowered to problem solve, we better support them when they try. For example, as Carrie discussed earlier, our CEO charged a rotating team of executives, nurses, emergency managers, and operations staff to come together to manage our incident command center for quick triage and issue resolution for COVID. She did a great job of this during COVID. She empowered the rotating incident command team to handle and escalate issues. She made herself available to the team, but she didn't place herself in the middle of every decision. She lets the system we built work, even when things heat up. Respect for people is a core lean principle, and in high stakes times, we ask even more of our teams than usual. When everything is urgent, high pressure, and high risk, it can be very rewarding because the sense of accomplishment and impact is high. However, it can also lead to rapid burnout as people sacrifice their work-life balance. It is so important for leaders to nurture our teams as whole people who dedicate so much of their time and energy to their work while navigating loss and hardships in their personal lives, achieving milestones, and they even have birthdays to celebrate. You can see in the picture on the bottom here how we celebrated one person's birthday. Sometimes we feel too busy to improve, and we're so busy doing what we do that we feel we cannot pause to take a step back and improve the way we do our work. And even harder to make the time to improve our own skills through training and professional development efforts. In trying times, we tend to put our own needs last. Ironically, there's no better time to challenge the status quo and invest in improving the way we do our work. It's the best time to work smarter and not harder. At UCSD, we've had to adjust our process improvement training offerings due to COVID, but we did not abandon them. Our in-person classes are now being offered virtually or in smaller socially distanced in-person classes. We also realized that people may only have 15 minutes to give themselves for training. So we created relevant and timely topics like how to facilitate process mapping in virtual environment or visual management during emergencies. I saw in the chat a lot of questions about doing improvement work in a virtual environment. And fortunately, with the technology that we have and a bit of flexibility, we've been able to do most of the work. There are some things that must be done in person, but we've been able to adjust our methods to allow for either social distancing or virtual meetings for going to Gemba, doing process mapping, and even hosting Kaizen events. Circling back on the importance of developing your teams, aside from creating space to attend formal training, daily development through leading as a coach to develop your team members' problem-solving skills can also make a tremendous difference in your team's ability to grow and make an impact. You're clearly already doing many of these things, as evidenced by taking the time to attend this webinar. Thank you so much for joining Process Palooza. We'd be happy to entertain a few questions you may have in the time remaining.
Thank you so much, Ashley. Very, very helpful to hear what leadership is doing. That's pretty amazing. I had a question. Do you have any advice for anyone who is looking to prioritize urgent versus important? Anyone else? I mean, I'm sure that that's happening in lots of places, especially in healthcare. But if someone is really looking for tools for prioritizing, do you have any suggestions?
Sure. I use Covey's urgent and important matrix as kind of a general guideline, but I tend to look at things on a level of complexity versus a level of impact, and really trying to focus the priority on those things that are going to be highest impact and the quickest to deliver that impact. Obviously, we can't only work on quick hits and low-hanging fruit, but being able to compartmentalize, what is it that you need to do now versus, maybe someone else can do it. Maybe it's a matter of delegating it or partnering with another group to get something done. And there's also probably a lot of things that we could be doing, but if the impact's small, maybe we should defer that and do that later. And I think one of the biggest challenges with prioritizing is knowing when to say no.
Yes, I have a really hard time saying no.
Most of us do.
But then when you realize that if you say yes to everything, you're saying no to a lot of things because they don't fit. And that kind of gave me my aha as well. So let's go ahead and invite everyone on the panel to open their video so we can all see you. And why don't we go ahead and answer some of the Q&A. Now, some of these might be directed towards some of you, and some of them are directed specifically to one of you. But I will open up the question again. Ashley did speak to it already, but I wanted to see if any of you, anyone else on the panel had some suggestions for operating in a virtual environment. Apparently there's a few questions. Daniel had that question, a lot of likes on that question. What are some of your biggest challenges in facilitating virtual work for improvement? And what have you used? Does anybody else want to speak to that as well? All right, Mike, go ahead. You raised your hand first.
Well, for better or for worse, I've become known locally as the Huddle guy. And so I'm going to talk to the specific challenges of holding huddles virtually. We've encouraged, as we've put in this daily engagement system, we've really encouraged in-person huddles, stand-up huddles at whiteboards, interacting with the visual management. But with the advent of COVID, some of these stand-up huddles just can't happen physically. And so some of the in-person huddles now happen virtually via Zoom. And they've been very effective. And so I just want to say that, yes, it's a bit of a barrier, but we now have many, many huddles that are happening very effectively via Zoom, fairly straightforward, standard Excel spreadsheets. Someone manages the spreadsheet, works through exactly the same content as you would do with a physical whiteboard. So if you haven't been in a huddle, this doesn't mean much to you, but for those of you who have experienced a stand-up huddle, don't be intimidated by the virtual environment and just experiment with a spreadsheet and use the PDSAs that we've talked about to work out how to do it virtually. The audio works. You don't really need to see people. You just need to see the information. It's visual management.
Anyone else? Anyone else want to speak?
I'd just like to add to that, there's online process mapping tools. I saw specific questions about process mapping. Mm-hmm. And whether you use an online tool or you just have a Zoom meeting like this and share your screen and use whatever tool, even if it's a whiteboard behind you with sticky notes. I think, Lucid Charts and ProMap and Visio and old school pen and paper and sharing your screen, you can actually do quite a bit by bringing people together virtually and walking through the process. We've had to be flexible in certain cases where not everyone could be available at the same time, and phone interview people individually and put together the rough draft and then bring everyone together to review as a group. It took a lot less of their time and got us where we needed to be quickly. So I think if you're a little bit flexible on what going to Gemba looks like, and being respectful of social distancing and those sorts of things, I think it's still possible to do this, and we've had a lot of success doing that so far.
Wonderful. One other question from Joanna. Are most employees' concerns brought up in the daily huddles, or have you had to set up a different tool for that? Who wants to answer that?
I can go ahead and answer that. Our daily engagement system is set up for employees' concerns to be raised at the huddle. I also noted something there about how do you get people to express their improvements or their ideas at a huddle. And I think first question, it should be brought up at a huddle. It could be brought to a manager. The benefit of the huddle is it can be escalated to whatever level it needs to be in order to be addressed. Now, how do you get people to open up? Well, you do over time, you show them that you're listening and you escalate, and not just escalate, but you cascade information back down to that huddle. And that's the really important part that many organizations really get stuck on, is what are the key things that need to escalate back down. And through time and trust and using the system consistently, I believe that a lot of people will start really relying on that and being able to bring things up in public with each other and try to do problem solving right there, or bringing it to their manager.
Thank you so much, Carrie. Okay, we have time maybe for one more question. Let's see, let's get a good one. Okay, how are you keeping the improved state after improvements were made and driving continuous improvement? How are you guys handling that whole, because sometimes, making it sticking the landing is hard. So what are some of the things you guys are doing to get people to be gymnasts and stick the landing? Who wants to speak to that?
I nominate Lily. She's really good at this.
Yes.
That's great delegation, Ashley.
We usually at THT, it's part of our center work is to develop a control plan toward the end of the Kaizen or RPIW events. And I use a recent example of a peri-op RPIW we developed. So we walk away with 50-some action plans. And then we have a really cross-functional system-wide weekly meeting, actually, to follow up those action items and then to assign owners and timelines and escalate if it's possible, if it's necessary, etc. So, and we celebrate. We have a THT monthly report out, and to celebrate, I think celebration is one key that we always forget to do. To give each other a hug. Good job. Let's continue this good work. Right. So I think that absolutely right is control to like Tracy, you said, 75% of the process improvement work might go back to where it was. It's our old habit. So to keep that control plan visible to all teams and keep the communication open, I think that's a key to continue the victory we have gained.
Wonderful. Thank you so much, Lily. I want to thank all of you from UCSD Health Transformational Healthcare. Thank you so much for coming and sharing your story. It was very, very interesting. I really enjoyed it. I learned a lot. And I also want to thank all of your essential workers who are keeping us safe and saving lives. I believe I can speak on behalf of many in saying we absolutely appreciate all of your hard work and dedication. So thank you so, so much. If I could give you a hug, I would. Right. So thank you so much for joining us today at Palooza Tuesday. You'll get an email with a survey, so let us know how we did and how the UCSD health team did today in sharing their story. And we hope to see you next Tuesday to learn about UC San Diego's Return to Learn program. So go ahead and register at processpalooza.ucsd.edu/Tuesday. Have a wonderful, fabulous Tuesday.